طبعا, welcome everybody to the second session of the second competition. And many thanks for the panelists for giving their valuable time to be evaluator and for devoting some of their time to be with us, to teach us and to teach the presenters, to give some valuable guidance. And of course, I would like to thank all the presenters who were very keen to participate and to present what they know and to add something. Just a very quick, let's say, overview of the instructions. Each presentation should not take more than 8 minutes. If it takes more than 8 minutes, the marks will go less, and this will affect the final result for the competition. And I would appreciate if the presenters could, the evaluators, the panelists, could just give questions or discussion within 2 minutes for each speaker. So total is 10 minutes for each presentation, because we have today 8 presentations. So we have 80 minutes, and we can give 10 minutes as a buffer. So total 90 minutes. So it is a long session. So please, for the presenters, I'm going to stop them at 8 minutes exactly, whether they finished or not yet. And I would kindly request from the evaluator after 2 minutes to stop asking questions and stop the discussion. So forgive me if I was tough a little bit, but just to control the time. And let us start with the first speaker. First presenter will be Dr. Khalid Al-Himyari, Knowledge, Attitude, and Practice about Wearing Glasses in Children. Evaluator will be Dr. Bara Al-Qubaisi. I think I have to give you the permission to share the screen.
Yeah, exactly.
Yeah, done. So you can start, please.
Sorry. Okay. Actually, it's my pleasure to share in the second competition of iTeach. My paper research today will talk about knowledge, attitude, and practice about wearing glasses among children.
We cannot see.
Parents.
Yeah, now we can see your.
It's clear with you?
Yes, now it is clear. So we can start.
Okay. My paper research today will be about knowledge, attitude, and practice about wearing glasses among children and their parents in Yemen. It's a hospital-based study. Globally, according to the WHO, 135 million people were living with uncorrected refractive errors. Uncorrected refractive errors is the leading cause of moderate to severe vision impairment.
Excuse me, Khalid, we can see only the first slide. You are not presenting in the, I don't know what is the share screen, the start. We can see the screen.
I already shared the
but
screen.
you are not.
I think
Yes.
you're sharing the screen, not the
I'm
PowerPoint.
moving the slide.
I think you need to go to presentation mode.
Yes, presentation mode. Start presentation mode. Start.
It's clear now.
It is clear, but start the presentation mode. To go from one slide
I
to
start the presentation.
Yeah.
Okay.
You're sharing the PowerPoint. Okay, you have two things. The PowerPoint presentation.
It's my PowerPoint shared to you.
And the show. You need to share the show, not the PowerPoint presentation. You'll find two things that you can share. So stop sharing the presentation and share the show. When you click on share screen, you'll find two options.
Yes.
So share not the PowerPoint presentation, share the show, the slideshow.
I'll stop sharing and come back.
Yeah.
Share your screen again, please. It is so easy. Share,
Yes, okay.
share your screen again, okay?
I choose the first slide out. It's okay right now.
It's coming.
Yes.
Yeah.
Go on. Thank you.
Okay, sorry for that. We can say uncorrected refractive errors are the leading cause of moderate to severe vision impairment and the second most common cause for blindness. The treatment is glasses. Glasses is the simplest and the cheapest method of management. Compliance was 40% according to the meta-analysis of 20 studies around the world. Do you hear me?
Yeah, we can.
Yeah.
But the slides are not moving. Just click any arrow, for example, or click on the screen itself.
So
Yes.
what's the causes of spectacles non-compliance? Actually, there are a lot of attitudes, beliefs, and misconceptions, such like fear of worsening the vision, fear of rejection from the opposite sex, long course management, and bad appearance, and fear of getting bullied by their colleagues. Okay, there is only 2 studies in Yemen about refractive errors and blindness. One of them mentioned that refractive error is the main cause of bilateral low vision in Yemen, and the third cause of unilateral low vision after amblyopia and trauma complication. The second study showed that prevalence of refractive errors was 8.7 among children in primary school. So what's the aims of my study? Generally, to assess the knowledge, attitude, and practice toward wearing glasses among children and their parents attended to the eye hospital, and specifically to measure the score and percentage of knowledge, attitude, and practice to determine the comparison of CAP scores according to age, sex, and the duration of wearing glasses, and finally to figure out the misconception of knowledge, attitude, and practice toward wearing glasses among children. Our study design was descriptive CAP cross-sectional study targeting 348 children with their parents according to the FPS formula for 3 private hospitals and takes for 1 year duration. So for the inclusion criteria, we included all the children wearing glasses at least for 1 month, in addition to the age between 6 months to 17 years old. And in the other hand, we excluded all the children with the first time glasses use, in addition to the age 18 years old and above. Regarding our questionnaire we used to collect the data, it contains 20 questions, 11 of them about knowledge scores, and 5 of them about attitude, and 4 about practice. We give 1 score for the correct answer, 0 score for wrong answer, and I don't know answer. We used SPSS version 21 for analyzing the data. For our results, we can see here in table 1, the mean age of our participants was 10 years old, and the mean duration of wearing glasses was 3 years old. And in figure 1, we can see that according to the age group, the most common age group was from 7 years to 12 years old. Actually, there is no differentiation between male and female in our participants who are wearing glasses. In this figure, we can say that our participants have a moderate knowledge with adequate practice while they have a negative attitude. So in this figure, we can see all the knowledge questions. We can determine this regarding the knowledge analysis. The surprise was that 40% of our sample have no knowledge at all about refractive error. And also 65% are looking for alternatives. In the attitude analysis, around 45% of our participants think that the glasses will badly affect the appearance, and they mentioned that their children get bullied because of wearing glasses. In this table, it actually showed that the more increase in age and the more increase in negative attitude with an adequate practice. And also, the long duration of wearing glasses corresponds to the more negative attitude. So as I mentioned before, actually 45% of our children were getting bullied because of wearing glasses, and around half of them are from 7 to 12 years old. And actually, the male was more than female to actually be getting bullied because of wearing glasses in our study. So my conclusion, in spite of moderate knowledge and adequate practice, our community have a negative attitude and wrong beliefs among the children and their parents about wearing glasses. Ophthalmologists and opticians share in educational level of parents toward the glasses. So they may try to correct the misconceptions and to try to tell the patients or tell the parents and their children what's the benefit of glasses and how could be avoided or treatment refractive errors. My home message is that misconception always cover the facts. So basic education must be improved through schools and screening programs must be replayed for schools' children. That's my references, and thank you for your listening.
Thank you very much, Dr. Khalid, for this nice presentation and nice study. So I'm going to ask you a practical point of view. So let's say that I'm a father or a mother of a child that comes to you to your clinic for the first visit, and you find out that he has a refractive error and he needs to wear glasses. And the father starts denying that he doesn't need glasses, and the mother starts crying. So in this situation, can you convince me as a father or a mom and explain to me the importance of wearing glasses?
Okay.
Do you understand the question?
Actually, I'll tell him that glasses is the only management for refractive error for your children until 18 years old. If you be regularly using glasses and visiting the ophthalmologist regularly, we can also manage the refractive errors. And if you are looking for alternatives, you can wait until 18 years old until the vision gets stabilized, and there are a lot of alternative then.
Okay. I think we got over time, Dr. Mazen. Should I ask him or continue for the next presenter?
Yeah, we have 45 seconds. You can ask another question, please.
Okay, sometimes the mom and dad starts to say that the refractive error is from each other. So how do you like get out of this situation and explain that it could be this or it's something else?
Actually, we have a high percentage of telling that the refractive error could be inheritance, and that's one of our questions in knowledge. So it's maybe it could be inheritance. So I told him refractive error, it's not type of disability if we use the glasses and if we try to get rid of from pulling from other colleges in our population.
Great. Thank you.
Right. Thank you very much, Dr. Khalid, Dr. Bara. And now the next speaker will be Dr. Dunya, sclerotherapy and lymphangioma case series, and the evaluator, Dr. Sumaya. Thank you both. So you can start sharing, please.
Okay. Hi everyone, can you see my screen?
Yes, please go on.
Okay. Hi everyone, good morning, good afternoon. I'm Dunya Ali, I'm a resident ophthalmologist. Thank you all for this opportunity. I'm glad today to share my articles. The topic of article is a result of intralesional bilomycin sclerotherapy for treatment of orbital lymphangiomas. This is the paper of our articles, supervised by Dr. Tariq Al-Duaismi and Dr. Ahmed. This is the content of our articles. Now we will start with the abstract. The purpose of our study was to assess the effectiveness intralesional vailomycin injection for treating orbital lymphangiomas. About the methodology, in this perspective, interventional case study, 6 patients with orbital lymphangiomas received interregional vailomycin injection at a dose of 0.5 milligram per kg with lingocaine 2%. About the result, 2 cases requiring retreatment receive injection at 4 weeks interval. Radiological review indicates successful outcome with proptosis, lid swelling, and exposure keratopathy being common presentation. Most of patients experience complete resolution of proptosis, although exposure keratopathy persistence. About the conclusion, to conclude, our study found no significant ophthalmic or systemic side effects, suggesting that intralesional vailomycin injection can be considered a primary treatment options of orbital lymphangiomas. Now we will move about a little bit about introduction. About the International Society for Study of Vascular Anomalies classifies lymphangiomas a combined vascular malformation with the venous and lymphatic characteristic. This is lesions in orbital very depth in size, superficial or deep, sometimes causing symptoms like global displacement, proptosis, strabismus, and optic nerve compression due to intralesional hemorrhage. The surgery excision is a primary treatment for lymphangiomas, but complete removal may not always be possible. Vailomycin has demonstrated effectiveness in treating disease growth. Now about methodology and material in our study. This prospective study was conducted at our orbital oculoplastic clinic of Rouad al-Noor Eye Hospital in Yemen from January to December 2023. 6 patients with a clinical and radiological diagnosed orbital lymphangiomas were included in this study, with exclusion criteria based in vailomycin sensitivity, loss to follow-up, renal or pulmonary impairment, pregnancy, and lactation. Vailomycin as sclerosing agent, biochemical action inhibits DNA synthesis and has FDA approval for treating various cancers like squamous cell carcinoma, testicular, and other malignancies. About the result, this table summarizes the demographic profile of the patients. All the cases, most of cases, pediatric group less than 13, except one case 60 years. Most of patients in our study, male patients more than female patients, and the presentation unilateral. About the presentation, actually the symptoms of our study are the patient presented with proptosis and lid swelling in all patients. 3 patients exhibit eye movement limitation and 4 patients develop exposure keratopathies. About the number of vailomycin injection, actually no proper guideline for the number of doses, the number of vailomycin injection. In our study, the range from 1 to 2, only 2 patients require 2 injections for optimum outcomes, while the remaining needed only 1 treatment for satisfactory outcomes. Additionally, all patients underwent cystic fluid aspiration before injection vailomycin. This is the case for case number 1, as we can see in this picture, before and after injection vailomycin. Coming with proptosis, exposure keratopathy, his condition was good, except exposure keratopathies. This is the second case, 2 weeks old old male patient with severe proptosis, exposure keratopathy. We can see in this picture before and after operations. His condition was good too, but exposure keratopathy is still. This is the third case. Female patient, 12 years old female patient, severe proptosis. Fortunately, she didn't have any exposure keratopathy, so her condition was good too. This is the 4th case with the patient, 2 months old with severe proptosis and severe exposure keratopathy. After the injection of vailomycin, his condition was good, except exposure keratopathies. This is the 5th case of 2 days male patient with severe proptosis and conjunctival swelling. There is no exposure keratopathy here. His condition was good too. This is the last case and the worst case, 60 years old female patient complaining sudden proptosis and lid swelling and exposure keratopathy. her condition actually wasn't good, and still the proptosis and the exposure keratopathies in her conditions. Now we will discuss about the discussion. Orbital lymphangiomas are benign lesions that can be serious. Could you hear me?
Yeah, we can.
اوكي انا فكرت انه لحظه wait. How can I share؟ لحظه. Sorry, I thought no one.
No problem. Yeah. Resume
Okay,
sharing.
wait. Okay, well, how can I do?
Just share again. That's it.
Share again. Okay, well. Wait. Can you see my screen or not? Can
Not
you
yet.
see or not?
No.
Not yet. Okay, wait.
Did you start sharing?
Yes, I will now. Okay. Now you can see or not?
Yes. Go on, please.
Okay. Sorry. Okay, about the discussion. What happened? The orbital lymphangiomas are benign lesions that cause serious symptoms and complications. Chemotherapy with the benomycin is effective treatment of lymphangiomas, reducing symptoms and potentially avoid surgery with minimal side effect reported in our cases. The number of doses, as we mentioned before, may vary. There is no border guideline for the number of doses. The common side effect, pain and erythema and swelling. So that's why we use systemic steroid for a 1 week prescribed to reduce the inflammations. Regular follow-up, no recurrency in treatment over 6 months. This is about the literature review. Motor and Roseman uses the interlesional benomycin for head and neck, Goding, Mary, and Rocher for orbital lymphangiomas, Comer for non-orbital lymphangiomas, all of them showing satisfactory outcomes. About the conclusion, interlesional benomycin is safe and effective first-line treatment for orbital lymphangiomas, showing no longer term ophthalmic and systemic side effect in our case series. About the statement of ethics, the patient and parent give their informed consent for publication on these articles in text and paragraph. Take a home message. Intralesional benomycin is a safe and effective first-line treatment for orbital lymphangiomas. The frequency of cystic lesion fluid aspirate barrier administration benomycin lower in this study compared to the previous one. This is my reference too, and thank you for your listening and attention. Sorry for interrupting and this. Thank you.
Yeah, thank you. Dr. Sumaya?
Okay, thank you, Dr. Dunya, for this interesting presentation, actually. But I have many questions. First questions, you consider it as a first-line treatment for all types of orbital lymphangiomas, or you have criteria for inclusion, either it's a macro or cyst?
Hello? Dr. Sumaya? Dr. Sumaya? You can start answering. The question was very clear. That do you have criteria or you just do it for everybody?
No, we have criteria. As I mentioned before, the patients if the patient have pulmonary or renal impairments or pregnancy or lactation patient, we excluding this patient, and also the patient who have benomycin sensitivity. So we exclusion this patient, and the patients do loose follow-up. We excluding in our study.
السؤال بحتة وانت بحتة ماما.
Dr. Mazen, we can't hear you.
Dr. Mazen, you're muted, I think.
Sorry. Okay. I was just giving an advice to all presenters that I would strongly advise not to use animation or animate. So let the slide as it is. Don't let the text come or go or the picture do that like this or like that, because this will distract the attention and this will waste time, especially with these very short presentations. Of course, this will not affect the mark, the final mark, but this is an advice. So, Dr.
Mazen, can you allow me also to add an advice?
Please.
If presenters a day previous can share slides with their colleagues and
Yes.
train to use Zoom, it's also a good idea.
Yeah, I agree with that.
Sometimes.
Thank you. I think Dr. Sumaya is facing some difficulty.
Can I ask her a question?
Please.
Dunia?
Yes.
Yes.
Yes, one of your patients was quite old. Is it common to get lymphangioma in this old age group? Because I was astonished of the last patient.
What? Could you?
The last patient
sorry?
was a bit older. The last patient was a bit older than
Okay.
the other group. So is it that common to get lymphangioma in this old patient, in this old age? Because this
Actually,
sounded
it's not.
atypical to me, because this sounded atypical to me compared to the other part of the cohort.
Yes, actually, as we mentioned before, no, all of the patient pediatric has had good response, but in this patient, as a CT scan and MRI shows intracornal and extracornal mass lesion as a differential diagnosis from eyes and heterogeneous enhancement as a differential diagnosis lymphangiomas. So that's why we try for this in patient intralesional bleomycin, but actually, unfortunately, the patient doesn't improve. I know maybe as maybe the tumor, maybe another tumor, but as MRI guided and we did this.
So did you consider taking a biopsy from her, for example, just to make sure that you are on the correct track?
Actually, we did it, but the patients, the results, actually, the results we didn't show, unfortunately.
I don't think it would turn out to be an lymphangioma. It's too typical for me to ensure.
Yes, because it is not typical. Yes, it's not atypical. But about the previous MRI, they say there's a differential diagnosis, so that's why we try. Thank you, doctor.
So I think let's move to the third.
Okay, thank you, doctor.
Shukran. And of course, many thanks to Dr. Sumaya. She's trying to join us. Whenever she joins us again, we can take some questions from her. Now, the third, Dr. Tariq, can you assist me? Who will be the third? Dr. Anas. Dr. Anas is not with us, I think.
Yes.
You are with us. Okay, great. So Dr. Anas will talk about OCT-based distribution patterns. And the evaluator is one of the presenters last time. And we are honored to have you on board, Dr. Youssef.
Thank you, Dr. Mazen, for inviting me.
Yalla, you can start sharing, Dr. Anas, please.
Okay. Hello, everyone. First, thanks for the panelist committee for their effort and for their time. I'm Anas Abu Saeed. I'm currently a PhD candidate at the Eye Hospital of Wenzhou Medical University in China. And today my presentation title is OCT-based distribution patterns of retinal complications in high myopia patients. So first, by 2050, half of the population worldwide will have myopia. 10% will have high myopia based on Holden study. Currently, 2 to 7% of older Chinese are high myopic, 1% elementary, and 20% in high school students. High myopia can cause severe visual complications, which lead to irreversible visual loss. So in high myopia, there is no unified classification for retinal complications. There is various classification previously used. First, Avila system was introduced, later modified, then Hayashi refined based on Tokoro, and later in 2015, Meta PM is the newest classification based on fundus image. So here's the international, the Meta classification. Maybe I need to. Okay, so the Meta classification are 4 categories and plus lesion. So the category number 1 is tessellated fundus. Category number 2 is diffuse chororetinal atrophy. Then category 3 is patchy chororetinal atrophy. And category 4 is macular atrophy. And here is the plus lesion. Lacular crack, CNV, and Fox spot. So limitations. Okay. Studies are that the fundus image will often miss maculopathies. There is a lot of maculopathies we can't see in fundus image, such retinoschisis. And OCT studies almost have small sample size. For example, for some studies, like the Singaporean study, was focused on less severe high myopic patient, while Peking eye study focused more on elderly patients, which don't represent younger demographics. So my study purpose is to analyze high myopia via OCT and to understand high myopia maculopathy's prevalence, identifies risk factors for complications, and addresses gaps in previous studies, investigate disease complication by demographics. So the method of the study, definition of high myopia is adult with axial length more to 26 millimeter, or myopic with a spherical equivalent less than -4 diopter for age 5 and less, -6 for age 6 to 8 years old, and -8 for age 9 to 15 years old. Retinal complications I included in my study is retinoschisis, macular hole, macular detachment, rhegmatogenous retinal detachment, epiretinal membrane, macular atrophy, and choroidal neovascularization. And the exclusion of diabetic retinopathy or genetic disease or any other unrelated retinal disease. So my data is I included patients from more than 9,000 patients at Wenju Eye Hospital. Lastly, 7,000 eyes of 3,733 high myopic patients were included with a clear OCT image obtained from year 2020. Initial OCT categorization was by one resident ophthalmologist, and another ophthalmologist, second ophthalmologist, were reviewed the OCT image. So here's my categorization of retinal complications. So it's 8 categories. Category 0 with no retinal complication. Category 1 retinoschisis. Here's the macular hole. macular detachment related to retinoschisis or to macular hole, rhegmatogenous retinal detachment, epiretinal membrane, macular degeneration, and CMV. Statistical analysis, the groups were stratified by gender, age, less than 20, 21 to 40, more than 41 years old, and axial length less than 28, 28 to 30, and more than 30 millimeter. And GE models were used to assess age, axial length, gender correlation using R software, and chi-square test evaluated the categorical variables. The demographics, total patients, female were more than males, 7,000 eye examined in total, mean age of patient 35 years old, females age range 3 to 95 years old, males age range 2 to 82 years old. So for highest prevalence in my study was retinoschisis. 9.3% of patients had retinoschisis. RRD had 6.7, epiretinal membrane 6.2 overall. Females have more maculopathies overall in high myopic patients. No gender difference in macular degeneration. And there was a significant difference in mean age between the different categories and axial length with p-value less than 0.05. Youngest patients were the no complication group. RRD also were in younger patients, females older than male overall. For axial length, shorter axial length were the no retinal complication. Also, rhegmatogenous retinal detachment categories will be shorter in axial length than other complications. The longest were macular degeneration category. So pediatric patients rarely affected with high myopia. Patients aged 21 to 40, the rhegmatogenous retinal detachment were most common. Patients more than 41 years old were the highest prevalence, with more than half patients and all patients will have complications. Retinoschisis 18.83%, epiretinal membrane more than 12.71%. And based on axial length, RRD most common was in lower axial length. In axial length 20 to 30, highest was retinoschisis. Axial length more than 30, mostly retinoschisis with 20%. Also epiretinal membrane with 16.84%. We also studied the tractional maculopathies, which is retinoschisis, macular hole, and detachment and the macular detachment to see how it related with epiretinal membrane. So tractional maculopathies was accompanied with epiretinal membrane.
Dr. Anas, 30 seconds.
Yeah, sure. Okay. So retinoschisis, macular hole, macular detachment increases with age. 18.83 retinoschisis in patient over 41, more common in female patient. Similar trend seen with other studies, but other studies focused on older patient. Some command more complicated, other milder. Broader age range allows comprehensive, and like in our study, enables thorough understanding across demographics. Rhegmatogenous retinal detachment more in males, middle age, and shorter axial length, consistent with general trends in other studies. Epiretinal membrane prevalence 6.4%, increases with age. Over 70% of tractional maculopathies include epiretinal membrane, suggests epiretinal membrane can be a cause, part of the mechanism of maculopathies. Our macular degeneration aligned with other studies, especially by age. Our study reports 1.4 CNV prevalence, which is lower than commonly other studies. Differences may be due to broader range and diversity. Axial length, in conclusion, age, axial length influence the severity of myopia. Female more susceptible to maculopathies. RRD more common in males, RRD notably prevalent in middle age, severity varied by age and axial length. And early detection is important in maculopathies, and we need more studies to study the gender disparities in myopia. And this is my references. Thank you.
Thank you, Dr. Anas. Yeah. Who will be the evaluator?
Yes, I'll be the evaluator.
Yes,
Okay.
please.
So thank you, Dr. Anas, for the excellent presentation. Just a couple of questions. What wasn't apparent in the study, you mentioned prevalence of maculopathy with OCT, but how much percentage of this maculopathy was not obvious on clinical examination or fundus imaging? So how many of those were silent on clinical examination and the OCT uncovered them? That's the real value of the OCT. So you mentioned, for example, macular detachment or rhegmatogenous retinal detachment. I think that would be obvious on clinical examination or fundus photography. So this wouldn't add the value to do OCT. How many patients were silent clinically?
Can you repeat the questions? Yeah.
How many patients, what percentage were normal clinically, but the OCT uncovered a pathology?
Like retinoschisis patients, more than 20% of patients. Like retinoschisis are sometimes they won't have any symptoms. So yeah, OCT will uncover this problem because we can't know the patient whether have retinoschisis or no with the fundus image. And also macular hole. Yeah.
Yes, sure. So another question, what kind of OCT machine did you use, and do you think it would make a difference?
Actually, different OCT machines, yeah, because like it's a hospital based, it's large data set, and yeah, some like in different times.
So do you agree that different OCT machines would would have different sensitivities to pick up macular pathologies in myopic patients?
Maybe, yeah. For example, maybe CNV, or yeah, maybe we need more like other tests to make sure whether patient have CNV or not. Yeah. So I think, yeah, maybe.
And with swept source, for example, or advanced spectral domain, you get a wider view of the retina, but with earlier versions, you can't see really details in myopic patients due to the weak signal. So different machines would be another issue here to consider, right?
Yeah, sure. Yeah, but mainly I just wanted here like to do prevalence, like focus on prevalence, on epidemiology. So
Yes.
we
And
need
finally,
to.
yes, sure. And finally, just a question for clinical application. So if you see a high myopic patient today in the clinic, would you go and do an OCT for any patient that's high myopic as per you defined in your study, or would you consider it in special situations?
Yeah, so maybe we consider it in special situation. Maybe in more patients, older patient will have maculopathy. So maybe we consider it more in older patient, and maybe younger patient if they have any symptoms or yeah.
Okay, thank you very much. Thank you very much, Dr. Anas. Thank you very much, Dr. Youssef. And let's move to speaker number 4, Dr. Lamia. Dr. Lamia seems she loves the nystagmus, and she will talk about various ophthalmic presentations of nystagmus. The evaluator will be Dr. Ali Yagan. Please share your screen.
Can you hear my voice?
Yes, we do.
Okay. Also, my screen, can you see them?
Yes.
Okay.
Yeah, start, please.
Okay, Bismillah. Good evening to all. It's my pleasure to be here tonight to present and share my research paper about discovering the underlying cause of nystagmus from the nystagmus characteristic. Can you see the next slide?
No, we cannot. Just click yes. Now we can.
Okay. The aim of the study is to discover the main cause of each type of nystagmus, also to determine the characteristic of nystagmus, which help me to localize the site of the lesion. Either it can be ocular, auditory, or neurological, to distinguish between the patient who need neuroimaging or to refer them to neurologist or need ENT consultant. The study was a case series study on 64 patients with nystagmus presented to Wad Noor Eye Center, Sana'a, Yemen, within 8 months. The study includes all nystagmus characteristics and focuses on the main cause. This study concentrates only on pathological nystagmus, not including the physiological type. This study also did not involve glaucomatous of the nystagmus patient and did not involve the nystagmus treatment for these cases. As an introduction, the nystagmus is rhythmic involuntary oscillatory movement. It can be horizontal, vertical, rotatory, or combined of this movement in their direction. The nystagmus can be jerk, pendular, variable amplitude and frequency. Some patients came with abnormal head position. So the normal ocular fixation is depend on 3 normal mechanisms: sensory visual pathway, vestibular pathway, and the neurointegrator. Any abnormalities in these pathways will cause the nystagmus. The pathological classification can be divided into congenital and acquired. So starting with the demography, from the 64 cases, 38 are female, the remainder are 26. Most of the cases was between the age of 1 year and the 10 years old. The main age was 2 years old. About 40% of the with the abnormal refractive error as hyperopia. More than half of the patient are not associated with a squint. Some are coming with the exo or vertical squint. The first case was associated with abnormality in the fundus. A lot of the patients came with abnormal fundus examination. This patient came with about, he was about 18 years old, came with abnormal, with nystagmus. It was bipolar, with a very poor visual acuity about hand movement. The fundus examination was retinitis pigmentosa. So the type of the nystagmus is congenital sensory nystagmus secondary to retinitis pigmentosa. I choose this characteristic to discover the underlying cause. Only 3 cases came with the unilateral. A lot of them came with the horizontal in the direction waveform. 54 of the patients came with the jerk nystagmus. Only 7 cases came with the abnormal head position or torticollis. The systemic association, about 41 of the patients are not associated with any systemic association. The surprises was 2 of the cases presented with auditory manifestations, so I referred them to ENT. 5 patients came with the neuro manifestation, but I refer 7 because 2 of them are presented with MRI findings with no systemic association. This is surprising case. About 2 years old boy came with the unilateral nystagmus as shown in the right eye, just unilateral for about 2 days. The full ophthalmic examination was normal. I decided to do for him an MRI. It was a mild hypoxic insult, so I referred him to a neurologist. He said this is normal. I asked about fever history. There was a fever history last month, so I sent him to ENT consultant. The surprise was acute otitis media in the same side of the eye of ear, so it was the peripheral vestibular nystagmus. This young boy is about 10 years old. 10-month-old. He came with bipolar and bilateral nystagmus. the fundus was bilateral optic atrophy. There is a history of the peripheral. Hello? Hello?
Yeah, you can go on, please.
Okay. Okay. There was a history of peripheral neuropathy. So the MRI was corpus callosum agenesis, which is important structure in the formation of the brain. So the type of the nystagmus is central nystagmus. This 13 years old lady came with the 1 year onset of the nystagmus. It is vertical. So any vertical nystagmus, I referred them to do MRI. The surprising result was Arnold-Chiari malformation, which is herniation of the cerebellum through the foraminogram. As we shown in this video, it is vertical. The fast phase is down, so it is downbeat nystagmus. Did I refer all the patients to do MRI? Of course, no. I referred only 18 patients. If abnormal nystagmus characteristic is present, vertical nystagmus and neurological manifestations. The last case is this 2 years old. He was uncooperative, so I entered him to examination under anesthesia to see the fundus. It was normal, but the surprising thing that the nystagmus before anesthesia was horizontal, and the other video after we waked him from the anesthesia, there was vertical nystagmus due to central depression from the anesthesia medication. So the result EUA can change the characteristic of the nystagmus. At the end, the type of the nystagmus according to the characteristic and the underlying cause is about 29 of the cases are congenital sensory nystagmus of different causes. At the end, the conclusion nystagmus is not always related to neurology. It can be auditory in cause. MRI is done if there are no ophthalmic findings, systemic symptoms, or history of trauma. Keep in mind, EUA can change the nystagmus of characteristic. The direction of nystagmus can give an idea about the site of the lesion. Those are my references. Thank you for your attention and watching.
Yeah, thank you very much for being on time, Dr. Ali.
Alhamdulillah.
Thank you. Very, very interesting study. From personal experience, people find nystagmus quite challenging to examine and to understand. What I found interesting in your speech, you talked a lot about characteristics of the nystagmus. Did you kind of try to look at the symptoms from the patient point of view? Was there any benefit from knowing whether the patients are symptomatic or not in your classification, do you think?
Yes, of course. For example, a lot of 4 cases came with me with retinitis pigmentosa, but they are presented obese and extra finger, so they are Bardet Biedl syndrome. 1 cases came with Down syndrome and mental retarded. So it is important to see if there is some systemic association. Also, one of the cases was about the video was associated with peripheral neuropathy, which is due to corpus callosum agenesis. So there is an important and association between the systemic findings and the nystagmus, because it's maybe from the central cause. It's not from auditory, from ocular auditory.
Correct. I guess what I was trying to say is whether your patient has any oscillopsia with their nystagmus, and that would suggest an acute or kind of an older onset, rather than patients who have congenital types of nystagmus usually are asymptomatic in the sense they don't feel the oscillopsia, so they don't present with the oscillopsia, and that would calm you down and push you towards not scanning these patients, rather than if they have oscillopsia, you're more or less going to scan them anyway. You mentioned the pattern of the nystagmus gives you an idea of the location. Give me examples, if you don't mind.
For example, the vertical nystagmus that as Arnold-Chiari malformation, she is downbeat. As I know, the Arnold-Chiari malformation caused downbeat nystagmus, and only for 1 year, so there is a problem in her MRI. This is an example.
Okay. Anything else that comes to your mind?
Yes, from my the seesaw nystagmus, I saw a lot of them, seesaw nystagmus, but I didn't.
Where's the lesion in seesaw?
It is in the paracillar, yeah, or maybe associated with some retinal problems as retinitis pigmentosa and albinism.
Not you get in.
But
in
more
these,
is paracillar.
Yes, you get what we call roving eye symptoms or roving eye nystagmus when you have very poor vision in RP patients. You get these movements that are in every direction rather than specifically CISO. CISO is more of a cellular, paracellular sort of lesions. But thank you.
You mean you're welcome. Thanks, doctor.
Thank you, Dr. Ali and Dr. Lamia. Now, before we move to presenter number 5, since Dr. Sumaya is with us and Dr. Dunya, if you would like to ask one question, Dr. Sumaya.
Yeah, sorry for this connection, but thank you, Dr. Dunya, for your interesting topic. I have a couple of questions regarding your study. You mentioned sclerotherapy. You hear me?
Yes, I can. Yes.
Yeah. You mentioned the sclerotherapy with bleomycin as the first-line treatment for lymphangiomas, but you didn't mention, is it for all types of lymphangiomas, or do you have criteria for inclusion in your study to start with bleomycin? And which patients, you said 2 patients underwent a second injection. Which patients need second injection? It's according to the size of cyst, the location of the cyst, is it deep superficial, or according to the venous flow? If you can explain more. And I have another question also. You have a high prevalence of lymphangiomas. Is it a tertiary center, referral center, or you related to which factors? Yani 1 year, 6 cases with these severe presentations. Can you relate it to any factors? Thank you.
Okay, thank you, Dr. Sumaya. Can you hear me?
Yes, sure. Yeah, I can hear you. Yes.
Thank you for thank you for your questions. I will answer the first one. The first one about about the inclusion criteria in our study. We use, as we mentioned before, exclusion criteria: the patient with bleomycin sensitivity and pregnancy lactation and loss of follow-up. We exclusion these patients. About 2 patients, we use the 2 injection. The patient who in 2 weeks with the proptosis and exposure keratopathy, we follow up 2 weeks and 4 weeks. We closely follow up with all the patients. After 2 weeks, they came the clinic. Then the 4th week. After 4 weeks interval, as I mentioned before, if patient that doesn't improve or didn't improve until 4 weeks interval, we did the another bleomycin injection. The only 2 patients, the old man female patient, and the last the patient, the baby with the 2 weeks old patients. Only these 2 cases patient. Only these 2 cases patient using for secondary injection bleomycin. Actually, the second question is about, yes, we closely follow up for all the patients, as we mentioned before, for second week, first week and second week and 4 weeks and third week and 3rd month and 6th month. We closely follow up for 6 months. Their conditions was good. And with bleomycin in our study, this is the aim of our study. Show the interlesional bleomycin was effective in most of patients. And that's it.
Okay.
You got it.
Yeah, I got. Thank you. And regarding the high prevalence, because it's a tertiary center, referral center, high prevalence of severe presentation, of cases. Your hospital is a tertiary.
In our clinic, the patients in Yemen, all the Yemen. Yes, I will tell you about the patient. There is no patient. There is no a lot in Yemen. The surgeon and the transfer all the patients for Dr. Tariq advice, because the only center who deal with this kind. Yes.
Okay.
And thank you.
Thank you.
Also, I want to answer to Dr. Ahmed. Sorry, Dr. Sinjab. Dr. Ahmed
no
asked
more
me
time. No more time. Thank you very much.
Just
okay. Okay, thank you, Dr.
Stay with us, Dunya. If we have time at the end, we can. All right. Now I'd like to invite presenter number 5.
Oh, okay. But I wanted to tell you. Okay.
Dr. Hashim,
thank you.
please, Dr. Hashim, start sharing your screen. And the evaluator will be Dr. Ahmed Awadin.
Hello, everyone. Do you see my screen now?
Yeah, but start it with the share mode, please.
What is the share mode?
You go down.
Start your presentation, I think.
Yes, start your presentation. Down, right. Go down right with your mouse, down right. Yes, click on this. Yes.
Yeah, that's right.
So, hello everyone, this is Hashim Abu Sarhan. I'm going to talk about tropicamide versus cyclopentolate for cycloplegic refraction in pediatric patients with brown iridis, a randomized clinical trial. I don't have any financial disclosures regarding the medications. This paper was published in the American Journal of Ophthalmology in last October 2023, and I was the corresponding author of this study. As a brief introduction for our project, active accommodation children is usually the primary source of error in measurements because of the ciliary muscle tone in children. So a lack of cycloplegia may result in overestimation of myopia or underestimation of hyperopia. So the cycloplegic refraction is the gold standard for determining the refractive error in children. We have many agents. They differ in onset of action, time to reach effective cycloplegia, and duration of action, including tropicamide, cyclopentolate, and atropine. And also, effective cycloplegia is affected by iris color and skin pigmentation, with the lighter iris colors more respond more to the cycloplegic agent comparison to the dark iridis and dark skin pigmentation. So atropine was the gold standard for cycloplegic refraction in the early 19 because of the strong potency. However, the long duration of action that can reach 2 weeks and well-known serious side effect that can lead to death in some of cases lead to paradigm shift in 1951 in the practice to the cyclopentolate use in cycloplegic patient because it's effective, relatively short duration of action, 24 hours to 48 hours, with fewer side effects compared to atropine. However, there is no free lunch, as they say. The drawbacks of cyclopentolate include many side effects like dryness of the mouth, skin, tachycardia, fever, hallucinations, seizures, and even in some cases, death. So the tropicamide is a shorter onset agent that can reach to maximum cycloplegia in 20 to 30 minutes with less duration of action, only maximum 6 hours, 2 to 6 hours. So they claim this advantage in the literature or in the practice especially that is the least effective cycloplegic agent compared with the other cycloplegia. So the knowledge gap that we don't have randomized clinical trials head-to-head that compare the cycloplegic effect between cyclopentolate 1% and tropicamide 1%. And when you read the literature, you will find that cyclopentolate may reveal plus 0.01 to plus 0.3 diopters more hyperopia than tropicamide, which is not of a clinical significance. The clinical significance was defined by Gupta as 0.5 diopter, half diopter, to say that this clinically significant. So our methodology was prospective multicenter randomized controlled study in 2 hospitals in Jordan between March 2022 and October 22, and the protocol was approved by the institution and registered in clinicaltrial.gov, and an informed consent was taken from all subjects, primary caregivers. Our inclusion criteria was patient were included if aged between 3 to 60 years and had a grade 4 to 5 brown iridis to overcome the difference in iridis color response to the cycloplegic agent, and could attend 2 separate exams within 12 weeks. And we excluded any uncooperative patient for autorefractive had abnormal red reflex, or had a history of heart and neurological diseases, or history of ophthalmic diseases other than refractive error or strabismus, or history of extraocular or intraocular surgeries, history of developmental delay or syndromes, or previous allergic reaction. So 2 cycloplegic refraction were done in 2 different outpatient visits within 12 weeks and separated by a minimum of 1 week to avoid the effect of, to be sure that there's no effect of the cycloplegic agent. And the patient were randomized to either cyclopentolate or tropicamide on the first visit, and the autorefractions were obtained before the installation of the eye drop and 30 minutes after tropicamide, which is the time to reach the effective cycloplegia, depending on Al-Omari study published in Strabismus, and 60 minutes after cyclopentolate. This is our drops protocol. And we assessed the mainly spherical equivalent change at the time of effective cycloplegia, and we grouped our patients into 5 groups: high hyperopia, metropia, myopia, and high myopia. And also we divide them into 3 age subgroups: group 1, 3 to 7 years, group 2, 8 to 11, and group 3, 12 to 16. And as we said previously, we considered half diopter difference is the lower limit for clinical significance. And this is proposed by Guha et al. Study published in the Clinical Ophthalmology and Optometry. So our results, the baseline demographics: 185 eyes from 94 subjects were included, with average age of 8.8 years, almost 9 years, and 45% of them were from the younger children, group 1, 3 to 7, 32 from the older, and 22% from the 12 to 16 teenagers. And the most refractive error was emmetropia. About here is the eye classification. The highest group was the hyperopia. So the main outcome for us is the average change in the spherical equivalent between tropicamide and cyclopentolate was statistically significant at 0.1 diopter. However, this is not clinically significant. So it proves our thesis or hypothesis that tropicamide could be effective like cyclopentolate. So it's statistically significant at 0.1 diopter. However, it's clinically insignificant. And this trend was seen in all age groups. Also, this trend was seen in all groups of the refractive error, in the high myopia, metropia, hyperopia, and high hyperopia. And the greatest effect of both cyclopentolate tropicamide was seen in hyperopic eyes. And as we said, this trend was seen in all refractive errors, range between 0.05 to 0.15 diopter, which is clinically insignificant. So the challenges for using cyclopentolate is mainly that time to reach effective cycloplegia in most of the studies, at least 60 minutes. And this lead to more waiting time in the clinic, less patient and parent satisfaction, and the duration of action cyclopentolate reach 24 to 48 hours, which can lead to absence in the school in the next day, with many reported adverse events in the cyclopentolate use compared to the tropicamide. So our suggested paradigm shift is to shift to tropicamide for cycloplegic refraction in the pediatric patient, because of duration of action only lasting 2 to 4 hours, which gives more less waiting time in the clinic, more patient and parent satisfaction, and only you need to wait 30 minutes, and some studies 20 to 30 minutes to reach the effective time cycloplegia. And it's safe compared with the cyclopentolate. And there is market conflict of interest. They produce cyclopentolate as the name cyclogel, just to give you in the subconscious that this is only for cyclogels, so for cycloplegia. And the tropicamide, they give the name midriasil, just to give you subconscious feeling that it's only for mydriasis, so only for dilatation. So you need to bring both the drops to your clinic.
Dr. Hashim, less than 1 minute. Less than 1 minute.
Yeah. And our findings were also agreed by meta-analysis published 28, find that there is no clinical significance between the two drops. Our limitations in the study that we didn't study the effect on the children less than 3 years, and also children with the strabismus, especially accommodative ESO at excessive convergence. And we are now ongoing trial on those patients with esotropia. And also in our study, we didn't factor the skin pigmentation and ethnicity. However, our population in Jordan is homogeneous regarding that. So our conclusion that tropicamide is equal to cyclopentolate in the cycloplegia refraction pediatric patient, despite regardless of the refractive error status. And thank you all.
Thank you very much for the presentation. This is the great work. I like the study design a lot. However, I'm always under the impression that they're different. I know that in many studies you find that the effect of cyclopentolate and tropicamide are similar, but in many countries, like Egypt, for example, sometimes we don't have cyclopentolate. So we have to use the tropicamide for cycloplegia. And when we compare the results of the cyclopentolate to tropicamide, they're different. They're never the same. So how to explain this?
Actually, doctor, when we do the head-to-head randomized clinical trial, usually the spherical equivalent at the time of effective cycloplegia will be the same for cyclopentolate or tropicamide. This was proven in our study and other published studies in the literature.
So how many drops did you put for the patient, and how many times did you put the tropicamide and the cyclopentolate?
Usually we put one Novocaine anesthetic drops before the installation of the cycloplegic agent. Then we will put one drop at 0 time, which means the first drop, then a second drop at 15 minutes, then a second drop 13 minutes for the cyclo. For the tropicamide at the 0 and at the 50.
Okay, so and then you waited how many minutes? You waited for?
Yeah, for tropicamide, we will wait for 30 minutes.
From the first drop or from the last drop? That's my question. And for the cyclopentolate?
Exactly, from the first drop. And for cyclopentolate, we will wait for 60 minutes, 1 hour.
From the first drop?
From the first drop.
Okay. And did you attempt to measure the refraction at different time to see when did the patient achieve the full cycloplegia? Like, for example, doing an autorefractometer at 30 minutes, at 40 minutes, 50 minutes, and to see when did you actually get the full cycloplegic effect?
Yeah, this is actually published. We depend on published study from one of the co-authors, is Dr. Rami Al-Omari, published a paper in Strabismus Journal 2021, and they measured the spherical equivalent at different time interval, and they found for tropicamide the maximum time to reach the effective cycloplegia is 30 minutes, and for cyclopentolate 60 minutes. That's why we didn't do this interval change, but we just depend on that paper.
Okay, I think one of the limitations for cycloplegia in children that they're not the same. For example, sometimes you may achieve full cycloplegia in some patient after 1 hour and for 1 drop or 2 drops, but sometimes you never get the full cycloplegic except after a longer time. So perhaps you needed to do this because this is the average time to get the full cycloplegia, but this is not the case for every single patient.
Yeah, maybe in that study, in the strabismus paper, 100% of patients, 100%, they reach the maximum cycloplegic effective at 60 minutes.
Okay. Anyhow, nice work, and it's great that you have it published. Congratulations.
Thank you so much.
Yeah, thank you very much, Dr. Ahmed and Dr. Hashim. Now, the sixth speaker is Dr. Athir and the evaluator, Dr. Suzanne. Athir, you are with us?
with you. Do you hear me?
Yes, we can. You can start sharing your presentation, please.
Okay. Moment, please. Is it shared with you?
Yes,
So
go
I will
on.
start.
Yes, please.
Okay. First of all, it is a pleasure for me to be with you again, participating in iTeach competition. Thank you for the nice invitation. I am Athir Mohammed Atiq, ophthalmology resident in my third year of residency in Arab Board of Health Specialization. Today, I'm going to talk about surgical outcome and of lateral rectus resection and medial rectus resection in the management of exotropia among Yemeni individuals. So as introduction, first of all, let's take a look about what is exotropia. It is a type of strabismus characterized by outward deviation of eyes affecting 1% of population, and it is more common in childhood. It is classified as primary and secondary. Primary classified as intermittent, and which is the commonest type, and constant exotropia, while the secondary exotropia either consecutive or sensory secondary to media opacity or fundus pathology. In Yemen, previous studies have showed that unilateral lateral rectus resection combined with medial rectus resection has been suggested as a surgical alternative for small and moderate angle of exotropias. Recent study evaluated that surgical outcome of unilateral lateral rectus resection in the treatment of moderate angle, which is less than 25 present diameter in children, found a success rate about 86%. Which is defined as less than 10 present diameter. Another study has reported that surgical success about 76% and defined as less than or equal to 10 present diameter, either ESO or exodeviation. The aim of this study is to evaluate success rate of unilateral lateral rectus resection combined with medial rectus resection in the treatment of exotropia among Yemeni individuals. Methodology, this is actually a prospective case series study of 67 patients with exotropia. All types of exodeviation with variable degree were included, both sex and variable age group also included. The period was 1 year from June 2022 to June 2023 at Ruwad al-Noor Eye Center, Sana'a, Yemen. Surgical intervention was done based on prism cover test at a distance of 6 meters after an adequate optical correction. Follow-up done in the next day, 1 month and 6 months from surgery. The final results were obtained, which was orthotropia in almost all patients. The study was performed according to the guidelines of Declaration of Helsinki. Ethical approval obtained by written consent from patient and data collected and analyzed by SPSS version number 21. The result was as the following. The mean duration was 11 years with a minimum 1 year and maximum 36 years. The age of presentation, mean age of presentation was 18 years with a minimum 2 years and maximum 50 years. Sex distribution was a little bit with higher degree in females in 25% and 47 in males. Refraction, OD and OS was actually a higher percent normal refraction in both eyes with a little bit higher percent of astigmatism OD and myopic astigmatism OS. Laterality, bilateral presentation in the majority of patients in 80%. Only unilateral in 10% left eye and 9% in right eye. 84% was primary, only 6 patients were with consecutive exotropia. Extraocular muscle movement were normal in the majority of patients, while limitation only in 3%. Ophthalmic exam were almost normal in both eyes. Anesthesia, type of anesthesia used here was general anesthesia, 85%, and only 10% underwent under local and 4% under topical anesthesia. Post-operative result, the final result of surgical procedure were orthotropia in almost all patients, representing 84%. Only 6% of patients presented with residual exotropia. Those are photos for real patients we have operated on pre and post operatively. For this discussion, I've compared our study with another studies have published before. Our study focused to evaluate the success rate of LR resection and MR resection in the treatment with a success rate about 94%. Another study has published before, done a comparison between the primary and reoperative outcome. It is a retrospective study about for 80 patients. Follow up at 6 months. There were two groups. Group A, here as we have seen, Group A for primary surgery and Group B for reoperation. The final result, they found that the mean angle of deviation were equal at the first day post-operatively. Then there were, after 3 months to the final result, Group A had become more exotropic. Surgical success rate was higher in Group B than in Group A at each visit post-operatively from 12 months to the final results in 83% in Group A. So in conclusion, for this study, unilateral R&R as a reoperation presented better result for the surgical treatment of recurrent exotropia, showing a smaller exotroph pattern and higher surgical success rate from the primary surgery. Another study has compared between recess and resect according to the pulse duction test and conventional R&R. This study, it is a retrospective in 128 patients done in Seoul National University, South Korea, the period 2006 to 2011. Two groups, FDT group and non-FDT group, follow up 4 years in non-FDT group and 3 to 2 years in FDT group. Surgical outcome was non-FDT group with a success rate 78% and R&R FDT group 89%. So in conclusion for this study, FDT is useful in reducing risk of recurrence after 2 years with R&R more than LR tension. So in conclusion, the success rate of unilateral lateral rectus resection combined with medial rectus resection in the treatment of exotropia among many individuals is promising. However, further research is needed to evaluate the long-term outcomes of this surgical approach. Those are my references, and thank you.
Thank you very much, Dr. Athir, for being on time. Yeah.
Welcome, Dr. Maz.
Dr. Susan.
Thank you, Dr. Athir, for your presentation, and you were just in time. I just want to ask you, you took the refractive errors. What about the visual acuity? Will it affect the outcome, the visual acuity?
Actually, the visual acuity, it will affect the visual outcome. All of patients who have operated on, we have done for them an appropriate optical correction and followed up after there is no benefit from any optical correction, we have operated on later on.
So you have about 94% have a success rate. Yes?
Yes.
And the 6% they had, they were not orthotropic. What about the visual acuity in those 6%? Maybe they were amblyopia.
They were already amblyopia, and they had fundus pathology. Those 6% of patients, about 4 to 3 or 9 or 5 patients, they had fundus pathology. Most of them were amblyopia or post-traumatic or with consecutive exotropia.
So what about the consecutive? How you will do the surgery? Consecutive, it means you had an esotropia, had the surgery for esotropia. So still you will do resection, the same procedure on consecutive? You will do the same procedure?
Yes, yes. They were only about 3 to 4 patients with consecutive. 2 of them consecutive and 2 were with fundus pathology.
Okay, what about the consecutive? How you do the surgery?
We've
They
done
had
surgery,
a medial rectus resection. They had medial rectus recession. So what you will do?
Actually, for this patient, we have done lateral rectus resection.
Yes.
Okay. And
what?
Exploration for medial rectus. Exploration for medial rectus. If there is
and what?
Yeah, if there is a benefit, Dr. Tariq operated for this patient. Actually, I was just collecting for the data, and I have no actual data about these surgeries. But I think if there is benefit from doing medial rectus resection, we can operate on them, or we can just satisfied with the lateral rectus resection.
I think you should exclude the patient with
yeah.
consecutive
We can
ectotropia from this study
be
because the
satisfied
surgery
with
differs.
Yeah,
Because the surgery differs. We are talking about a virgin eye, non-touched lateral and medial rectus. So if you go for consecutive, there was already a surgery, so the result will be much different.
Yes,
believe me,
the
you can
result
find
won't be that
not the same,
that
and it
good
will
as
affect.
the
You
virgin
should
eye.
take it out from the data, and you will exclude them. Otherwise, this is the usual presentation to do the lateral rectus recession with medial resection for exotropia, and you aim for overcorrection because exotropia usually tend to recur. Thank you very much.
Thank you. Welcome.
Yeah, thank you, Dr. Susan. Now, Dr. Ali would like to add something.
Can I very, very quickly? I find this very, very interesting. I mean, as you might know, my background interest is squint in adults, basically. A couple of little comments, if you like. I think the follow-up period is very short for squints, so you only followed them up for 6 months, and that would explain why your success rate is 90 plus. I think if you follow them longer, it'll drop down as time goes by.
Actually, we are working on
Yeah,
this,
I mean, it's prospective cover,
for
a prospective study, so you might as well continue to monitor them. The other point was, as Dr. Suzanne mentioned, I think you need to differentiate between patients with binocularity, i.e. it's an exophoria rather than an exotropia, which would have better outcomes compared to exotropes, which you need to overcorrect anyway, as you mentioned. I found it interesting that some of your patients were done under local anesthetic, and specifically you mentioned topical anesthesia, which is, I'm sure it'll be very, very painful for such patients, but I found it interesting. We tend to do nearly all our patients under general anesthetic anyway. And the last point I was going to mention is you kind of need to separate, as Dr. Suzanne mentioned, you separate the consecutive exotropes, because these you will do recession advancement, which will give you a completely different sort of dose response curve. Yeah, it's you're not resecting the medial rectus anymore. You're advancing it back to original insertion, and with that you get much bigger response. So it's completely different kettle of fish. You can't really compare them with your virgin muscles resect. But that's my suggestions.
I will take this in my mind.
Thank you.
Okay, great. Thank you very much.
Thank you, Dr. Ali. Thank you, Dr. Susan.
Yes, thank you, Athir. Now, there is, I think we have Dr. Kariman. Are you with us?
Yes, Kariman is with us.
Yeah. So, Kariman, would you please start sharing your screen? Of course, Dr. Tariq will be the evaluator. Dr. Kariman, are you with us? Can you hear us? We cannot hear you well. We can see the slide that you have started, but we cannot hear you. No, still the voice is not clear. Not yet. Try to log out, log in again, please. Or adjust the microphone. The voice is very, very low. Dr. Tariq, presenter number 8, Dr. Sarah, is here or she did not?
Sarah not here.
Not here. Okay, so Kariman will be the last, but not the least. But we want to hear your voice.
Same technical problem, Dr. Kariman.
Log out, please. Kariman, leave us, Karim, log out and then log in. Yeah, meanwhile, if any of the panelists would like to ask any of the presenters any question or have any comment, that will be great.
حبيت أعلق على دكتور علي بالنسبة لللوكال أنستيزيا بالسيكونس سيرجري. حقيقة أنا في العراق يعني دخلت اللوكال أنستيزيا للسيكونس سيرجري من سنة تقريبا 2008 2007 تقريبا. We started for the adult. هي السيرجري بحد ذاتها ما راح يتغير بها شيء، بس حقيقة it will be longer because we should be more keen when we are pulling the muscles and the patient awake. We usually spend time talking. All the surgery we are talking with the patient because it's a long surgery and he will be anxious. Then we started to do it on younger ages. Believe me or not, we are now doing even 10 years. 10 years of age if they are they have a logic enough, and if they are cooperative, we do for at 10 years. But for topical anesthesia, I just try to do a botulinum injection, depending on topical anesthesia. But in Malaysia, I once or twice I saw researchers, they presented their cases. They usually do it under topical for adults, but I didn't try it only for botulinum.
So the experience here is similar. I think my predecessor used to do it quite a lot on local anesthesia. It's ease of access. We have general anesthesia available readily, so it makes it easier and more straightforward. The Botox is always under topical in with us. So, and again, I don't do pediatrics, so for adults it's always topical. As you said, the challenge is logistical with the local anesthesia rather than technicality. I guess you need to be a bit careful with pulling the muscles and not kind of stopping patients' heart and stuff like that. But apart from that, it takes a little bit longer.
By the way, once you give it a local anesthesia, so pulling the muscle, it will abolish the ocular cardiac reflex. So in fact, it is less serious than during general anesthesia.
Yeah, can I share my experience also, because I work a lot with local anesthesia for like at least 20 years. The beauty about eye muscle surgery is that we are always opening the intermuscular space. So it's very easy for me, if the patient felt pain or the local anesthesia doesn't work, that we can augment the anesthesia using a posterior subtenon anesthesia. So it's quite easy. Whenever you would like to just augment it, you can just do it without feeling any problem, because you already opened the intermuscular space, as compared to cataract and glaucoma surgery, which is not a routine step.
Yes, exactly. You can augment it, yes. And usually I tell the anesthetist to give a combination of lidocaine and bupivacaine, so to make it a longer effect.
Nice remarks. Thank you very much, all of you. Now, Kariman, are you ready?
Can you hear me now?
Slightly better, but still low.
Okay, try to start. Let us see.
Can you hear me now?
Yeah, better.
Better?
Better, yes.
Sorry.
But I think you need to make your voice as much loud as you can.
Yeah, so try to shout.
Because we can just barely hear you.
I'm now trying to share my screen. Is it okay?
Yes, we can see your screen, but not the presentation.
Is it now? Can you hear me now?
Yes, go on, please.
Okay. I'm so sorry for this technical problem. I'm very glad. I'm very happy to be among you. I'm very thankful and grateful to all panelists for their time they spent to evaluate our thoughts. Introduction. I have no conflict of interest. Diabetic retinopathy is the most prevalent microvascular complication that may lead to that may be manifested by progressive vascular abnormalities in the retina. These abnormalities remain asymptomatic at the beginning, but may lead to vision-threatening conditions. And ventricular coagulation prevent extreme visual loss in patients with diabetic retinopathy. However, laser treatment has a few complications due to retinal inflammation triggered by laser burn itself. Aim of the work. We study the peripapillary retinal fiber layer thickness and peripapillary capillary density changes in diabetic eyes following ergo laser pan retinal photocoagulation. Patients and results. This was a prospective study of 100 eyes of 62 patients with diabetic retinopathy. Inclusion criteria: severe non-proliferative or proliferative diabetic retinopathy. Exclusion criteria: subjects had history of intraocular surgery, glaucoma, uveitis, retinal detachment, and clinical significant macular disease. Follow-up: oscillatory angiography was used for measuring the peripapillary and retinal fiber layer thickness and peripapillary capillary density before and after PRP by 2 months and 6 months. This is a printout that we made analysis for them. Figure A is the patient pre-PRP. Figure B is the same patient 2 months post-PRP. Figure C is the same patient 6 months post-PRP. This black arrow indicates the thickness map, and this red arrow indicates the capillary density map. Our results show, first, for the retinal fiber layer thickness, we found that the thickness increased from baseline to 2 months post-PRP and decreasing gradually from 2 months to 6 months post-PRP. For the capillary density, we found that the capillary density decreased gradually from baseline to 2 months post-PRP and decreasing more and more from 2 months to 6 months post-PRP. Discussion. For the thickness, we found that our result was agreement with some studies that explain the temporary increase in thickness after PRP due to retinal inflammation and edema that resolved later on. For the capillary density, our study revealed significant reduction in the peripapillary capillary density following conventional PRP. As we see in this figure, this is peripapillary capillary density pre-PRP, this 2 months post-PRP, and this is 6 months post-PRP. As we see, the capillary density decrease obviously. This in agreement with many studies that reported a significant reduction in the peripapillary retinal blood flow after PRP using laser spectroscopy. Summary. Our study showed a significant increase in thickness at second month of follow-up that may be related to laser-induced intraretinal inflammation that increased capillary permeability due to cytokine release. For the capillary density was gradually decreased after every session of PRP and was reduced significantly after 6 months of PRP. Take-home message. Many studies recommend micropulse diode laser that is more safe and has less destructive effect on the retina. In the yellow diode laser, the device can deliver subliminal and subthreshold microsecond pulse laser to stimulate, not ablate, the retinal pigment epithelium. Also can be used for PRP photocoagulation. We recommend future studies that focus on comparing the argon and diode laser PRP regarding their effect on the retinal outflow and the retinal nerve fiber layer thickness. Here is my reference. Thank you very much for your kind attention.
Thank you, Dr. Kariman, for this nice presentations. Optic nerve blood flow and retinal nerve layer fiber with PRP. My first question, how can you measure capillary blood vessels in your study?
I use it velocity angiography. There is a capillary density map that we that angiography we use average of the quadrant, superior, inferior, and temporal and basal quadrant. We take the numbers and we made average for them. Then we make analysis.
Can you study different when you use multiple shot of laser rather than unishot? Different stage of laser?
For our patient, we made the same parameters and the same method for laser for all the patient to make the changes between them not by the same setting and the same power and the same time for the laser treatment.
Okay, anyone want to ask?
Yes, Dr. Youssef.
Yes, I just want to add just looking at the numbers, I know you said there's statistical significance, but if we look at the numbers, there are differences between the first and second month were about 2 microns in the retinal nerve fiber layer thickness, and in the OCTA, the density, it was 1% or 2% difference. So there is variability. If I do OCTA on myself and OCT retinal nerve fiber layer, I'll get 2 different numbers if I do it 2 different times on the same day. So we need to look at these differences with a grain of salt. Just wanted to add that.
Yes, okay. Yes, some images we repeat some images till we reach the fixed number that is mostly is the same as the previous image. But actually, every moment that we take image, we found slight different number, but we take the average number of images.
All right, great. I think Dr. Ali would like to add something.
Very, very briefly, I think, again, thank you, very, very interesting. It might be useful doing volumetric scans and looking at the volume of the structure rather than just the thickness of it. And what might be also useful is looking at these different segmentations. So for example, for the nerve fiber layer, you can trace it back to the ganglion cell layer and see if there is any change in the ganglion cell layer, especially in the macular area, which will give you a better kind of clinical correlation, I guess, rather than just statistical analysis. Thank you.
We now prefer to make analysis for a larger number with longer duration by comparing the ganglion cell complex, retinal fiber layer, and capillary density with argon laser and diode laser, and also using yellow laser, not diode only, but also yellow laser with micropulse technique.
Okay, that's great. But Kariman, you have to fix your microphone for next competitions. Otherwise, we will exclude you. Okay, so at the end of this session, it was very interesting session. A lot of interesting topics. All are very high caliber. So it will be very difficult for us to choose the best of them. So thank you very much for presenting such interesting topics. And of course, I want to thank very much the evaluators for their time and for the valuable comments that they gave. And if any of the evaluator would like to add any comment, we still have 5 minutes before saying good night.
Just to say thank you to Dr. Mazen for all the effort on organizing this. It's really refreshing to see this. And thank you for asking me to be part.
It's a great pleasure, actually. Of course, the aim of this platform is to encourage the young ophthalmologists to shorten the time for them to reach what we have reached, actually. And of course, I would like to thank Dr. Tariq Al-Da'is because he exerts a lot of efforts in order to organize and make all of this happen. Thank you very much, everybody, and have a good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much.
Wa alaikum assalam. Good night.
Good night.